Good morning, Chairman and Co-Chairman. My name is Anwar Wayayok from Ramatipidi Hospital. Today, I would like to present my topic, ACL injury when we need osteotomy. I would like to thank my advisor, Associate Professor Natapon Sangpech, for the advice and guidance in presenting this topic. The ACL injury is one of the most common conditions observed in sports competitions, and you may have seen this type of injuries in contact sports such as football, basketball, or rugby. Occasionally, ACL injury are also seen in non-contact sports. The cause of ACL injury may include twisting from contact or non-contact sport, or caused by internal rotation and varus force, valgus force, and external rotation, and hyperextension. Currently, the gold standard for treatment is ACL reconstruction, which aims to help patients return to their normal life and sport activities as quickly as possible. Although we hope for the best outcome for the treatment, there are certain factors that can lead to the failure of ACL reconstruction. According to a study of Bryson Kemmler about failure rate for ACL reconstruction shows a failure rate of 3.2%, which may rise to as high as 11.1% in some study. The most frequent cause of failure is a traumatic non-contact injury. There are so many factors contributing to ACL reconstruction failure, such as tendon placement, graft choice, inadequate graft fixation, missed PLC injury, high-grade pivot sheath, early rehabilitation, and another important factor is excessive posterior tibial slope. In another study, Xuan Yushun and his colleagues conducted a systematic review to explore the risk factors that lead to ACL reconstruction failure. The study found several factors, and one of these factors is osseous deformity, such as a posterior tibial slope and coronal limb alignment. And when these factors are categorized, they can be divided into three groups. First, technical factors, such as tunnel placement, graft choice, graft size, graft tension, or graft fixation. Second is patient factors, such as age, BMI, and return to sport activities. And the last is status of the knee joint, such as meniscal injury, posterior tibial slope, and coronal limb alignment. When considering limb alignment and how it affects the ACL tendon or graft, alignment can be categorized into coronal alignment, sagittal alignment, and axial alignment. In terms of coronal alignment, there is a study by Gerrit Jan van Diepoel, which conducted a biomechanics study on 6 human cadaveric legs. It was found in the study that varus alignment and ACL tension are directly related. The presence of varus thus increases the tension of the ACL, while the ACL deficiency also causes a greater lateral joint opening. And the study by Bettina Hingel on mechanical varus and ACL stress found that mechanical varus, as a result of ligamentous deformity of less than 10 degrees, was responsible for increased ACL stress, particularly at 0 and 30 degrees of knee flexion. In the case of sagittal alignment, several studies have shown that posterior tibial slope directly affects ACL tension. In this picture, the tension on the ACL increase as a result of increased anterior tibial translation and an increased tibial slope when the quadricep tendon contracts. In contrast, a decreased tibial slope leads to lower tension of the ACL. A study by Robert Griffin on the effects of tibial slope on knee biomechanics found that increasing tibial slope improves stability in PCL deficiency knee, while decreasing tibial slope improves stability in ACL deficiency knees. This shows a direct relationship between posterior tibial slope and ACL tension. In many studies on tibial slope and its effect on ACL tension, tibial slope greater than 12 degrees has been found to increase the risk of ACL reconstruction failure. For example, the study by Justin Webb found that a posterior tibial slope greater than 12 degrees had an odds ratio of 5.2 for ACL reconstruction failure. The study by Ehab Nazal also found that a tibial slope greater than 12 degrees is a risk factor for ACL reconstruction failure. However, some studies use a tibial slope of 10 degrees as a cutoff point. For example, the study by Ali Fares found that a tibial slope greater than 10 degrees was associated with 5.7 times higher risk of ACL graft rupture. In conclusion, current evidence suggests that most studies consider a tibial slope greater than 12 degrees as the cutoff point that increases the risk of ACL reconstruction failure. Regarding axial alignment, the data is still limited, with only a few studies show its impact on ACL grafts. For example, the study by Dr. Lighty found that a tibiofemoral angle greater than 4.5 degrees increased the odds of ACL reconstruction failure. And the study by Kelly Shern that examined the relationship between TTTG distance and ACL also found that an increased TTTG distance was a risk factor for ACL graft failure. However, there is still no study on the use of osteotomy to correct rotation in patients undergoing ACL reconstruction. The question remains whether we should always perform alignment correction in cases with coronal malalignment and excessive tibial slope during every ACL reconstruction. The answer is not yet clear. There are studies that suggest that slope-reducing osteotomy give good result. For example, Forian Imhoff study on ACL graft force under axial load compression found that after performing slope-reducing osteotomy, the ACL graft force under axial compression load decreased. Another study by Francesco Bosco, a systematic review and meta-analysis also found that ACL reconstruction combined with high tibial osteotomy restores knee stability and function with satisfactory clinical and radiological outcome in patients with ACL injury associated with high posterior tibial slope. Regarding the use of high tibial osteotomy to correct varus alignment, in conjunction with ACL reconstruction, many studies have been conducted. For example, Frank Noyes' study on high tibial osteotomy combined with ACL reconstruction found good functional outcome and allowed patients to return to normal activities in daily life. Another study by Stefano Zaffragnini also found that high tibial osteotomy combined with ACL reconstruction yield good clinical outcomes in midterm results. However, performing high tibial osteotomy in primary ACL reconstruction still has some conflicting evidence. For example, several studies have shown good outcome from ACL reconstruction alone, such as the study by Sung Jae Kim, which examined ACL reconstruction alone in case with varus knee, but without medial compartment knee osteoarthritis. The study found good knee stability and good functional and radiological outcome. Similarly, Roberts Dean explored the role of correction in primary ACL reconstruction and found that valgus-producing and slope-reducing osteotomy were more common in revision ACL reconstruction, with only a few studies conducted in primary ACL tear case. In the case of revision ACL reconstruction, osseous alignment is a key factor in ACL graft failure. Several studies have shown that in the setting of revision ACL reconstruction, slope-reducing osteotomy and valgus high tibial osteotomy lead to better treatment outcome. For example, Tiako Wiwakwa study on closing with posterior tibial slope-reducing osteotomy in complex revision ACL reconstruction found that tibial slope-reducing osteotomy result in a significant decrease in anterior tibial translation and can be considered in patients with preoperative posterior tibial slope more than 12 degrees. Another study by Antonino Contivoli found that high tibial osteotomy with revision ACL reconstruction may be a viable option in young patients with anterior instability and medial knee osteoarthritis, showing good midterm outcomes. A study by Ho Hyun Won on coronal limb alignment and the indication for high tibial osteotomy in revision ACL reconstruction found that patients in revision ACL groups had more varus malalignment and medial compartment knee osteoarthritis than in the primary ACL group. Therefore, high tibial osteotomy should be considered in revision ACL reconstruction with varus malalignment greater than 5 degrees. Whether it is high tibial osteotomy to correct varus alignment or slope-reducing osteotomy, most studies have focused on revision case. There are still limitations in the performing osteotomy in primary ACL reconstruction case, and more research is needed. In conclusion, returning to the question, when to consider osteotomy in ACL injury, it must first be categorized as primary or revision. In the case of primary ACL injury, if the patient had coronal malalignment and an indication for high tibial osteotomy, combining high tibial osteotomy with ACL reconstruction provide good result. However, in case with high tibial slope greater than 12 degrees, slope-reducing osteotomy is gaining more evidence, although further study with larger sample size are needed. As for axial alignment, there are still insufficient data. In the case of revision ACL reconstruction, combining high tibial osteotomy with ACL reconstruction in patients with medial compartment knee osteoarthritis give good result. And slope-reducing osteotomy should be considered for case with posterior tibial slope greater than 12 degrees. Thank you.
Thank you, Tan, for your excellent presentation.